One thing we can't escape as physician associates are medication. Be you a student, a newly qualified physician associate, or even a seasoned veteran. The thing is, humans fall sick, and sometimes a simple advice is enough to treat whatever ailment they might have. On other occasions, we have to intervene with medications to hasten this process. The problem is there are a whole lot of pills and tablets running amok on this planet. Knowing your left from your right is definitely not a skill to underestimate. This is because a good understanding in pharmacology allows for a safe and effective prescribing of medications. Now hold your horses. I know we do not prescribe currently as physician associates, however, eventually that day would come. But for the time being, if we are going to ask our prescribing colleagues to prescribe based on our clinical judgment, I think the least we can do is know what we are talking about. This goes from understanding the mechanism of action of the medication in question, why it is used, when it is used, the side effects, the contraindications. The amalgamation of all this knowledge is what sets apart a true clinician from a protocol robot. And I've been guilty of this, and dare I say I'm still learning. An understanding of pharmacology does not only allow you to prescribe well, it also allows you to be an effective communicator to the patients. Gone are the days when a clinician's opinion was a divine revelation to a patient. These days, with a widespread use of the internet and the warm embrace of Dr. Google, patients do have questions, and guess what? They will ask them. If you do not have a solid foundation to reassure them and answer their medical questions, that fundamental clinician-patient relationship will without doubt be affected. The trust will be eroded. As I said, there are a whole lot of drugs running about in this country, from legal to illegal. Yes, illegal because our patients are not saints, and an appreciation of this can come in handy on occasions. Finding time to go through all the medications in the UK is definitely not a small task. It is so vast, the sheer amount of information and things you have to learn, that there are whole degrees dedicated to them. If we are to put in context the relatively short duration of the physician associate program, the masters, the PhD, maybe those doing the 4 years might experience it in a different way, and the amount of clinical information packed therein, it goes without saying that time is rationed. Some will differ. Some people feel their courses did indeed prepare them enough to be prescribers. Others feel it was not enough. In my language in Tree, we say, what they want not done right. It's like saying if you don't have a skin in the game, you can chat all the nonsense you want. When you were a medical student, when you were a physician associate student, you learn these medicines in books. If you've never had an actual patient sitting in front of you needing this medication, trying it, not working, having side effects with it, your appreciation of said medication is different. Which brings me to what one of my tutors back when I was in PA school used to call P drugs. Now, I don't quite remember when he said P drugs, this was for personal or preferred drugs. I think I'll go with preferred drugs. This was the notion that with time and experience, one could develop an arsenal of medications frequently prescribed that one knew like the back of their hand. The same way Drake knows all the women he fumbled. As a PA, no one can force you to become an expert pharmacologist. However, failure to grasp the basics will definitely come at a cost. Not only will you recommend the wrong medication for the presentation in question, your dosages might be wrong, and you'll definitely not take into consideration the various drug-to-drug interactions, the state of the kidneys, liver, and a whole lot more. You might also be thinking, alright, since as a physician associate I don't prescribe, the onus is on someone else to do the due diligence and check all these things. That is in part true. However, if you are expecting your colleagues to prescribe for you and you are over there recommending that they prescribe kryptonite to Clark Kent, do not be surprised if they start looking at you sideways. In my humble opinion, we have a duty to our colleagues to protect their numbers. Let's get to the chase. The GMC is not really a friendly organization to doctors. Every time they are prescribing for you, they are putting their number at risk. We have a duty. Me, I'm not perfect. I try to do my best. I feel scared to F up when someone trusts me. Not in the sense of I don't want to make a mistake, but acting in a manner where an oversight on my behalf would negatively impact someone. It feels like a betrayal to me and I don't want it. So the choice is yours. You can stop watching this video now or you can follow me down the rabbit hole. There are many ways one can become a pharmacopro, from attending seminars, conferences, reading journals. However, as clinicians, we don't have all the time in the world. If that were not the case, I would just recommend rank and dale and just call it a day. Did you see what I just did there? Dale and day? No? Guys are a tough crowd. Instead, I recommend the top 100 drugs. It's a lovely book, and hear me out. This book covers the top 100 drugs regularly prescribed within the UK. And I have no doubts you've definitely encountered most of them. The book is written in an easy to understand style, far from any dense academic textbook. The layout of the different sessions also makes it a breeze to find information. Also, the ability to go through the book, either based on the system in question, cardiovascular, gastrointestinal, neurological, or by the various drug indications, means your trip to Mount P drug will definitely be accelerated. I know it's called the top 100 drugs, but as you're probably aware, it's not just a list of medications. It covers the mechanism of action, the indication, the dosage, administration, and a way more. And also there's a section in the book, I think it's called clinical tips, which gives insight from experienced clinicians on the medication you are looking at. A cherry on top that should definitely not be overlooked is the question session at the end of the book, which tests your knowledge on the different aspects of the medication, ranging from the indication, the side effects, the contraindications, and the various drug-to-drug interactions. You will find this style of questioning particularly useful because it will readily highlight your weakness and pinpoint with GPS precision what you need to review. I think you'll find this book very valuable, regardless of how far down the journey you are. I found it useful when I was a physician associate student, and 2 years down the line, I still find much value from it. Of course, this book is not the end all be all. The BNF still exists. Your local guidelines and national guidelines are still a thing. Make sure to consult them when needed. But as a tool to brush up on your pharmacological knowledge, I think it's second to none. And when regulation comes, you'll definitely be prepared for it. Click on this video to see how physician associates might prescribe in the future. It's your boy OT, and I'm out. Salute.